Welcome. Today we're looking at some really important information for healthcare providers like you. We're focusing on serious viral infections in children.
Okay, so the main focus is Echovirus 11. That's ECHO-11. This one is causing severe, often deadly infections in neonates.
Neonates, so birth through the first 28 days.
Correct, that first month of life. Now, Enterovirus 71, or EV-71, is also mentioned. It's known for causing serious brain and nervous system problems, usually in slightly older infants and children. But the information we're discussing today really goes deep on ECHO-11 in those newborns.
Right, ECHO-11 in those very, very young infants. How does that usually look, clinically, I mean? What are the worst outcomes?
Well, it often looks like a sepsis-like illness. You know, it presents very similarly to a serious bacterial blood infection.
Okay.
And this often comes with major liver problems, liver dysfunction, and issues with blood clotting, coagulopathy.
And how fast are we talking? Does it develop quickly?
That's really the frightening part. It can progress very rapidly. It can spiral into multiple organ failure surprisingly fast.
Wow. Which organs are typically involved?
It hits the liver hard, causing acute hepatitis and sometimes outright liver tissue death, which we call hepatic necrosis.
Okay.
It can affect the heart, causing inflammation of the heart muscle, myocarditis, and it can get into the central nervous system, causing inflammation of the brain and its linings. That's meningoencephalitis.
So it mimics sepsis, hits multiple organs, and just moves incredibly fast. How are these tiny babies getting exposed in the first place?
A really key way is transmission from the mother around the time of birth. The mother might have the virus but show no symptoms herself.
Vertical transmission.
Exactly. So the baby gets infected and then develops the severe disease very early on.
And you mentioned the outcomes. They can be pretty devastating.
Yes, definitely. The data is quite stark. One European group reported a 60% mortality rate among preterm infants who got ECHO-11.
60%.
Yeah.
In preterms.
Yes. And autopsies often show that widespread liver damage, the hepatic necrosis, and also a severe clotting problem called disseminated intravascular coagulation, or DIC. And for those who survive, especially the preterm babies, they can face long-term problems like neurodevelopmental impairments or ongoing heart issues.
60% mortality. That's just incredibly high. It really highlights how vulnerable that group is. Okay, given how severe it is, what makes it so hard to diagnose these enteroviral infections in newborns?
Well, the biggest issue is that the early symptoms are just not specific. They look almost exactly like bacterial sepsis. So this can cause delays. You might not immediately suspect a virus, and that could delay considering antiviral treatments, if any effective ones were available and easy to give.
And the speed you mentioned.
And the speed, yes. That's the other huge factor. A newborn can go from seemingly okay to critically ill in just 24 to 48 hours. It's incredibly fast.
Looks like sepsis gets worse extremely quickly.
Yeah.
Yeah, I can see the diagnostic challenge. So what tools do we have then to help identify the infection or figure out the extent of the damage?
We heavily rely on molecular testing, specifically reverse transcription polymerase chain reaction, or RT-PCR.
Okay.
That lets us find the virus's genetic material in samples like blood, spinal fluid, or stool. Then for the organ damage, we track things like liver enzymes in the blood.
Like AST and ALT.
Exactly. Aspartate transaminase and alanine transaminase. If those levels get really high, say at or above 1,000 international units per liter, that's a significant sign of liver involvement.
Okay. And for the heart?
For the heart, we look at cardiac biomarkers, things like troponin and brain natriuretic peptide, or BNP.
Got it. So RT-PCR for the virus itself, standard labs to track the damage. Once it is diagnosed, how do we manage these severe acute infections?
The absolute foundation is aggressive supportive care.
Right.
If the baby's in septic shock, that involves using vasopressors medicines to keep blood pressure up and get blood flowing to the organs. But importantly, you have to be careful with fluids, especially if there's myocarditis. That heart muscle inflammation, giving too much fluid, can be harmful.
Okay. Are there any specific treatments aimed at the virus or the inflammation itself?
Well, for the severe liver inflammation, the acute hepatitis, some have used N-acetylcysteine, but the information suggests this is mostly based on anecdotes, not strong trial data.
I see.
Intravenous immunoglobulin, IVIG, is also used sometimes in severe cases, usually a dose of about 1 gram per kilogram. But again, the data specifically backing its effectiveness for these enteroviral infections is pretty limited.
Any antivirals?
There's a drug called pleconeural. It does show activity against the virus in the lab, in vitro, but there just aren't human trial data for using it in neonates at this point.
So it really comes down to intensive support. While the specific targeted treatments are still lacking solid evidence or availability for newborns, that really puts the focus back on prevention and early recognition, doesn't it?
It absolutely does.
What about in the newborn intensive care unit, the NICU? Are there specific strategies that are critical there?
Yes, preventing spread within the NICU is crucial. Cohort isolation is key, grouping the infected babies together to stop transmission to others.
Makes sense.
And if you have twins or triplets and one gets infected, it's recommended to have screening protocols in place for the siblings, even if they seem okay.
Right. Proactive screening.
And another important point, doing post-mortem viral testing when there's an unexplained neonatal death. This helps identify hidden outbreaks and understand the real causes.
Those are really practical steps for the unit level. Thinking a bit broader, how can we prevent transmission, both in healthcare settings and maybe even out in the community?
Educating mothers is really fundamental. Simple things like meticulous hand hygiene before touching their baby. And advising them to keep the baby away from anyone who has a fever. For healthcare staff, it means strict contact precautions for any suspected case. And enhanced cleaning of surfaces is very important too. Remember, enteroviruses are tough. They can resist alcohol-based hand sanitizers.
That's a really critical point about the hand sanitizers. Standard disinfection is needed. What about higher-level public health actions?
On a wider scale, things like mandatory reporting of severe pediatric cases help track trends, and genomic surveillance that's tracking the genetic makeup of the virus is necessary to spot new or changing strains like the ones causing recent concern.
Let's talk more about spotting the severe cases early. Are there specific signs, factors, indicators that strongly suggest a baby is likely to have a poor outcome? What should clinicians really be watching for?
Yes, there are several factors linked to a worse prognosis. Being born preterm, having a lower gestational age is a big one. High viral load is another. If the virus level is very high, say over 10 million copies per milliliter, that's associated with poor outcomes.
10 million. Wow.
Also, very high ferritin levels in the blood. We're talking over 1,000 micrograms per liter, maybe even over 2,000 international units per liter, depending on the assay. That's a warning sign.
Ferritin, okay. What else?
A rapid rise in the International Normalized Ratio, the INR, which measures clotting time. If that INR jumps above 2.0 within just 24 hours, that's a major concern.
Right. Indicating coagulopathy is worsening quickly.
Exactly. And extremely high liver enzymes, AST or ALT, at or above 2,000 international units per liter, that also points to a worse prognosis.
2,000, okay.
And finally, having both myocarditis, the heart inflammation, and meningoencephalitis, the brain inflammation, happening at the same time, that combination is strongly linked to poor outcomes.
Those are very specific, very useful markers for clinicians to track in real time. You mentioned genomic surveillance and new variants earlier. Are there recent examples that highlight this current threat?
Oh, absolutely. Especially with Echovirus 11. We've seen recent clusters of severe neonatal infections pop up in Europe and Asia.
For instance?
Well, France reported 9 cases just last year in 2023, and sadly, 7 of those babies died.
Oh, goodness.
And Taiwan reported 3 severe cases early this year in 2025, which resulted in 2 deaths among neonates.
Okay.
And significantly, the genetic sequencing from those European cases, it showed a new distinct lineage of ECHO-11. So now researchers are trying to figure out if this specific variant is actually more virulent, more likely to cause severe disease.
So a new strain might be emerging.
It really underscores why that continuous genomic surveillance is so important to catch these changes as they happen.
It definitely sounds like ECHO-11 is a pathogen we need to be very watchful for right now. What about the babies who do pull through a severe infection? What does the information say about their long-term picture?
Well, survivors, particularly those born preterm, can face ongoing neurodevelopmental challenges, problems with brain development and function. And if the initial illness involved myocarditis, that heart inflammation, then chronic heart dysfunction can be a lasting consequence.
So the effects can linger long after they leave the hospital.
Yes, definitely. It emphasizes the need for really comprehensive long-term follow-up and support for these children and their families.
Right. Okay, so pulling this all together then.
Yeah.
The information clearly points to Echovirus 11 reemerging as a really significant threat, especially for newborns, alongside the known risks of Enterovirus 71 in older kids. What's the main takeaway message for healthcare providers listening?
I think the core message is the need for a really high index of suspicion for enteroviral disease, especially in neonates who present with those sepsis-like symptoms.
Vigilance?
Yes, vigilance. And knowing those specific warning signs we discussed, the super high ferritin, the rapidly climbing INR, the extremely high liver enzymes, recognizing those early is key. Aggressive supportive care is, right now, the main treatment approach. That's the cornerstone. And while research is definitely ongoing for better treatments, antivirals, maybe even vaccines down the line,
Right.
our best defense currently comes down to strict infection control practices and just rapid identification and supportive management of these unpredictable viruses.
That's incredibly clear, practical advice. Thank you for walking us through all that.